We'll move on to our next case. Dr. Thangamani presenting from Medicine 1, Exotic Pus.
Good morning, everyone. I'm presenting on behalf of Medicine 1. My topic is exotic pus. So, presenting a 56-year-old female, Mrs. Y, housewife from Kadapa, admitted on September 19, 2024 under Medicine 1 with presenting complaints of rapidly progressive swelling in the right side of the neck for the past 15 days, which was associated with breathing difficulty for 4 days. History of presenting illness: she was apparently well before September 5 when she developed swelling in the right side of the neck, which was sudden in onset, rapidly progressive, associated with severe pain, associated with dysphagia and odonophagia. And on September 10, after 5 days of this onset, after September 10, she had 3 episodes of loose stool, which was watery, small, not associated with blood or mucus, and associated with 3 episodes of vomiting, which was non-projectile, non-blood stained, not associated with abdominal pain. She went to the local hospital and was admitted for loose stools from 10 to 15. 14 and 15, she got discharged. And the loose stool stopped on 11th itself. And she was admitted for the neck swelling and high sugars. For the loose stools, she was admitted in the local hospital. And then she was discharged on 15. And again, later she developed breathing difficulty after 2 days, she developed a breathing difficulty, which was for 4 days, which was sudden, progressive, MMRC grade 2 to grade 4. No history of chest pain, palpitation, or syncope, no fever, no cough, no abdominal pain, or no decreased urine output. And then no evening raise of temperature or night chills, no running nose, sneezing, or headache, or dysuria. So she treatment history wise, she received, so after she developed a breathing difficulty, she went to the same hospital and she received injection meropenem metroclindamycin for 1 day, and then she was referred here for further management. Past history wise, she is a known case of diabetes mellitus for the past 6 years, but she was irregular on treatment, not taking oral antibiotic drugs properly, and known case of CVA 1 year back. And she is a known case of systemic hypertension for the past 6 years on regular medications. Known case of hyperthyroidism for 10 years on tablet neomercosol 10 mg BD, and postmenopausal lady. So examination wise, general examination, she was conscious, oriented, not in apparent distress. Pulse rate, there was no tachycardia, no hypotension, no tachypnea, afebrile, but there was hypoxemia, which was settled with initially 8 liters of oxygen, then gradually tapered. No pallor, icterus, cyanosis, clubbing, and there is a irregular mass of 10 into 10 centimeter in the right side of the neck, which was tender, which was shifting the right earlobe. And systemic examination wise, positive findings as respiratory wise, there is a right side crepitations over the interscapular and bilateral crepitations over the interscapular and infrascapular areas, more on the right side. And other system examination is normal. And the on summarizing, 56-year-old female with uncontrolled diabetes, which was presented with a sudden onset swelling in the right side of the neck, which was tender. So the differentials we considered was infectious causes of Staphylococcus aureus, Streptococcus, tuberculosis, and milioidosis, and non-infectious causes are lymphoma, thyroid nodule or malignancy, metastasis from occult malignancy, and Castleman disease. So initial investigation showed leukocytosis with the neutrophilic predominance, and there was reactive thrombocytosis also. There was anemia, which was found to be iron deficiency anemia, and electrolytes were okay, no AKA, and blood culture was taken on serially on 18, 19, 20, which was showed no growth, and HbA1c of 13.3. And we suspected TB, so we have taken sputum expert, which was negative. And we have done FNAC and biopsy of the ultrasound guided FNAC and biopsy of the swelling, which was also showed inflammatory granulation tissue biopsy only. But the pus culture expert also has grown negative. It was negative for TB. But the pus culture has grown non-typhoidal salmonella, which is susceptible to meropenem. So we have proceeded with the cross-sectional imaging before that, which was ill-defined necrotic lesion in the right side of the neck at the level 2 and level 3, most likely nodal origin. So the pus culture has shown non-typhoidal salmonella. So we come to know the life cycle of non-typhoidal salmonella was, it is the inhabitant of intestine of cattle, poultry, and reptiles. So from the intestine, it was excreted in the fecus. That fecus contaminates the soil. From that soil, we humans infect, and it enters the intestine and multiplies in the intestine. Through our fecus also, it contaminates the soil. From that soil, it infects other humans also. And this is the meta-analysis, 84 studies from 35 countries. which was the total presentation of how non-typhoidal salmonella presents. So the most common presentation of non-typhoidal salmonella is shock only, 20.4%. And only 4% of patients from all over the studies presented as an abscess, not only neck abscess, all over the body. So only 3 case reports are for 4% of this. All the 4% of patients, mostly 80 to 90% of diabetic, all were treated as incision and drainage, which was mostly susceptible to meropenem. And there are only 2 case reports are there, which was present. Non-typhoidal salmonella, which is presenting as a neck abscess. Only these 2 case reports are there. These both case reports are diabetic, uncontrolled diabetic. All as pus culture has grown a non-typhoidal salmonella, which was antibiotic targeted therapy was given. After incision and drainage only, they became okay. So in our patient also, we have done incision and drainage. We treated with the 14 days of meropenem, and she got discharged. Other thing, the respiratory system we found because of the hospital acquired pneumonia, she had patch in the right lower zone, and that's all. So learning points is one of the rare infective causes of neck abscess is non-typhoidal salmonella. It usually occurs in the immunocompromised states such as diabetes and HIV, etc. So it requires incision and drainage in most of the cases published. Targeted antibiotic is needed. Thank you.
So non-typhoidal salmonella is mostly a pretty benign disease. I think less than 10%. For most people, it's just a self-limiting bacterial illness. And actually, if you see it in stool cultures of people with acute gastroenteritis, they may actually not even need antibiotics. So it mostly resolves on its own. In a small minority, it becomes bacteremic illness, which then is similar to typhoid in that it can seed anywhere. So actually, in this case, it was a neck abscess, but in any part of the body, it can seed and form, empyema. One of the high mortality complications are mycotic aneurysm. So I think those are people who don't do well. And yeah, they tend to be in immunocompromised people, especially HIV is one of the typically described situations. I think it's not so much, there's not so much in India, but in Africa, continent of Africa, when especially in places where there's a high prevalence of HIV, it's much more common. And there's just some geographic, differences that we have more salmonella, but for whatever reason, non-typhoidal salmonella is not that common around here. For this patient, sorry, I didn't see the drug resistance. Was meropenem needed, or were there other antibiotics that?
Yes, ma'am, she required to meropenem. The susceptibility was it was susceptible to.
Yeah, it was probably worth downgrading there to ciprofloxacin or ceftriaxone, since to prevent further drug resistance and use an antibiotic sparingly. Does anyone else have any comments or questions? Sure. Thank you. Next, we have Dr. Brightus presenting from Medicine 2, Fragmented.